Okay, hello everyone. Yeah, this is another session. We're moving to the second topic under the clinical psychology. So this time around, we'll be looking at mood disorders, and under that, we have two types. We have the depressive disorder, which is also known as unipolar depression. Okay, and then we have the bipolar disorder. All right. So basically, the depressive disorder is just the one segment which talks about the sadness level. All right. When we look at the bipolar disorder, on the other hand, we're talking about a combination of both extreme level of happiness and extreme level of sadness. So it's a combination. That is why it is bipolar by representing two. Okay. So moving forward, we have the diagnostic criteria. We're also going to look at the explanation as well as the treatment. Okay. For the diagnostic criteria, mood disorder include depressive unipolar and bipolar disorder. All right. Now, it's characterized by mood episode that occurs over time. Okay, over time. Actually, it's not a one day thing. It's not something that just happened in a few days and you already feel okay. Yeah, I have mood disorder. No. Okay, it's normal for people to experience sadness at some point or extreme level of happiness at some point, but if it exceed a certain period of time, then you can begin to watch out for mood disorders. All right. So mood episode are key components, not diagnosed separately. Okay. Mood actually episode are periods marked by specific mood states, such as number one, depressive episode, number two, manic episode. All right, which is a mania. We have mixed episode, and then we have the hypomanic episode. Now, hypomanic is just a mild version of the mania, not extreme happiness like manic episode itself. All right. So the depressive episode is just the singular sadness part, whereas the mixed episode is the combination of both. Okay. Yeah. Moving forward, what are the key terms? Episodic mood disorder, a disorder characterized by distinct period episode of abnormal mood state. All right, abnormal mood state. You can be moody; it's not a problem. But if it's becoming abnormal, like excessive and lasting for a long period of time, then there is a problem. We have the manic episode, a period minimum 1 week. All right, it has to be a minimum of 1 week of extremely elevated mood. The mood is elevated, high. You want to try this, you want to jump that, you want to go fly, you want to go do a lot of risky and adventurous activity. All right. So you have heightened energy level and then impulsivity. Okay. Now, the next one is the mix episode, a 2 week period with simultaneous feature of both manic and depressive state. So it's a combination. If it's mixed, then it's a combination, which is also known as the bipolar. All right. Now the depressive episode, a period minimum of 2 weeks. So mania or manic is a period of minimum of 1 week. This depression is a minimum of 2 weeks, marked by depressive mood or loss of interest in activity nearly every day. Okay. Yeah. What about hypomania? A less severe form of manic episode. All right. So it's still a mild form, right? Lasting several days with elevated mood and increased activity. Okay. Psychometric testing. This basically talks about a way of testing, okay, through maybe questionnaire or some other things. All right. The measurement of psychological variable, e.g., emotional states, using standardized questionnaires and numerical scale. All right. So moving forward, depressive disorder. What are the key characteristics? Depressive mood, feeling sad, irritable, empty, or a loss of pleasure. Okay, so these are the behavior, or let me say the explanation. So, what is depressive disorder? This is a situation where someone or a participant or whatever, okay, someone feel extreme level of sadness, irritability, emptiness, loss of pleasure, etc. over a long period of time. Usually lasts for, or let me say, usually above 2 weeks. All right, something like that. So you can coin out your definition using those keywords. Okay, now accompanying symptoms: difficulty concentrating, excessive feeling of worthlessness or guilt, recurrent thoughts of death or suicidal ideation, changes in eating or sleeping patterns. Okay. Yeah. So what about the diagnostic consideration for depressive disorder? All right. If you want to diagnose someone for that, okay, the person must not have any history of mania. You might wonder why. After all, we've been speaking about mania and depression together, right? So if someone is going to be having the unipolar depression, the person must not have any mania. If it has mania, then it's going to be bipolar. I hope you understand that. So, but if it doesn't have any form of mania, then it's going to be depression alone. Okay, so a diagnosis rather of unipolar depression disorder is made only if there is no history of mania, mixed episode, or hypomania episode. All right, so it's a single episode thing, single episode depression disorder, one depressive episode with no prior history. Okay, so recurrent depressive disorder, two or more depressive episode separated by several months without significant mood disturbance. Okay, so if you're going to have recurrent depressive disorder, you can have not just one but two or more depressive episode, okay, over a period of month or whatever the situation may be. Okay, now what are the criterias? Weeks minimum. A depressive episode must last at least 2 weeks to meet the diagnostic criteria. I believe that's cool, right? Now, days of symptoms, depressed mood, or a significant decrease in interest of activity. All right, we mentioned this earlier. So, what about bipolar disorder? All right, this is episodic nature. That is, it moves from mania to depression. Okay, so bipolar disorder are episodic, involving swings between high and low moods. All right, so what is high mood? Mania. What is low mood? Depression. So we have the main type. We have bipolar 1, bipolar 2. Okay, so what is bipolar 1 disorder? Defined by at least one mania or mixed episode. All right, so once you have a mania alone, then it is bipolar 1. Once you have mania and depression, then it is still bipolar 1. Why did I say, okay, once you have mania alone, it is already bipolar? So you might think, okay, mania alone, it's a one-way thing, right? Which is just one episode. So far, you've not experienced depression, then it is not bi. But there is the belief that once you experience mania, the fact remains that, or let me just say, everything that goes up comes down, right? So there is an automatic belief that anyone who experiences mania must resort back to the depressive episode. So once you have mania, it is already a symptom that the person is having bipolar. That is 2 episode. The person will eventually have the depression over time. Okay, so I believe that is taken. Now the manic episode lasts at least 1 week. All right, very important. Okay, characterized by extremely elevated or euphoric mood. Can also be irritable. Okay, where the person is just hyperactive. He wants to do this, he wants to do that. Okay, you know. Right. Symptoms include increased talkativeness, inflated self-esteem, impulsivity. All right. May cause significant impairment in functioning. All right. So there's a possibility around that. All right. What is bipolar 2 disorder? On the other hand, we have it is defined by the occurrence of one or more hypomanic episode. All right. So it can be one hypomania or two, coupled with at least one depressive episode. Excuse me, please. So there must be at least one depressive episode as well. All right. So this situation, one or more of this, and at least one of this. So that forms the bipolar 2 disorder. So in other words, this is it focuses generally on the hypomania. All right. So the hypomania is not as heightened as the mania itself. Okay. So the bipolar 2 disorder, we can say to some extent, is you experience the lesser version of the mania. All right. So hypomania or hypomanic episode now. How does it look like? A less extreme form of mania episode involves several days of persistent elevated mood or increased irritability, accompanied by increased activity or energy level. Okay, symptoms are noticeable but less severe than in full manic episodes. Okay, so how do we measure depression? All right. uh, uh, yeah, there is BDI. We have BDI. Okay, there are also other questionnaires that can be used to measure mania, but in this study, all right, they did not particularly talk about mania beyond the diagnostic criteria. So they just give the explanation when it comes to bipolar, and the other information given in the course book more towards the depression or the depressive episode. Okay, so we can use BDI to measure depression. All right, it's a widely used self-report measure for detecting and assessing the severity of depressive disorder. All right, so please keep this information in mind, very important. It consists of 21 items. This might be a mark for you if you're being asked to describe the BDI. So note is 21 item. Each item has at least 4 statements. So when they have one item, for example, as you can see the structure here, so there can be an item there which talks about something, and then you have 4 statements, 1, 2, 3, 4, maybe 4 a point under it. All right, so you have to pick the one that explains your mood. All right, so respondents choose the statement that best describe their feeling over the past week or two. All right, so yeah, so still on the BDI, it measures feeling of satisfaction, your level of satisfaction. It measures hopelessness. It measures weight changes, guilt, fatigue, and other depressive symptoms. All right, so it is a scale of 0 to 3. You know, we mentioned 4 points, right? So the 0 can be something like, I get as much satisfaction out of things as I used to. All right, so if the person picks 0 now, that means the person is not really having depression when it comes to the level of satisfaction, right? All right, so look at 1. I don't enjoy things the way I used to. So there is a sign. I don't get real satisfaction out of anything anymore. So this is more becoming general anymore. All right, anything. 2. I am dissatisfied and bored with everything. All right, so you can see the level of severity, right? So it has a scale of 0 to 3. All right, please keep this information in mind. 21 items, 0 to 3. Okay, you can memorize one of those things. All right, also it measures symptoms including satisfaction, hopelessness. Just remember at least 2 of this. Okay, moving forward, the scoring guideline. All right, so total score of around 10, or let's say something around 10. Okay, or 10 to 18 is mild depression. Okay, if the person falls below 10 now, then can be regarded as the person is still fine. Okay, but from 10 to 18 is mild depression. Moderate depression is 19 to 29. Okay, I don't know how you can memorize these two, but it's very, very important. Moderate depression, 19 to 29. Very important. Okay, and then score of 30 and more is severe depression. Okay, so please keep this in mind. It is very, very important. All right, research method for assessing depressive disorder. What is the advantage? It provides objective numerical data because you have to pick numbers, right? So it is objective, which is good. All right, it can also be easily compared between one participant and the other. Standardized administration to enhance consistency. Okay, so the self-report is well standardized, ensuring consistency each time. Okay, now compared to unstructured interview, so this one is more consistent. You have a structured kind of question, all right, and then the person has to select the exact one that matches his feeling over the past week or two. All right, limitation, it is a self-report, so the idea might be exaggerated. Okay, social desirability, which can reduce internal validity, right? What about cultural biases? Developed in Western context may not translate accurately to other culture. So that's an issue around that, okay? So let's move on. Yeah, there's an activity you can describe or design a new measure of depressive symptom. You can try that out, okay? Analyze different points that you note that, okay, depressive symptom might have 1 or 2 things to see around. Okay, and then you have different questions under them. Okay, moving on. Explanation of the onset of depressive disorder. Okay, Now, environmental factor. Traumatic experience can cause it. Okay, for example, abuse, loss, or major life change. All right, adverse life events that trigger stress and negative emotion can also be a cause around the environmental factor. Right? What about biological factor? Okay, genetics can cause it, brain chemistry can also cause it, talking about the neurotransmitter. Okay, so let's move into the explanation. Genetical factor in depressive disorder. Family studies indicate a higher risk among first degree relatives. Okay, some studies suggest a genetic predisposition of mood disorder. All right. Um, when we're talking about first degree relative, we're talking about relationship between, for example, father and children, or let me say parents and children. So they are directly related, okay? Not between uncle that is a little far away, okay? So just keep this in mind, please, very important. Okay, there is a higher risk among first degree relatives compared to those that are not related. So just higher risk. Okay. Moving on from there to the biological explanation. Now, dopamine. We mentioned dopamine when we spoke about schizophrenia, right? That those with schizophrenia tends to have high level of dopamine in certain part of the brain. Okay. Yeah. Now, looking at dopamine again, what is dopamine? We said dopamine is a chemical that is responsible for motivation and other things, right? Now, low level of dopamine can lead to diminished pleasure, right? And motivation, okay, which signifies a feature of depression. Can you see the relationship there? So, does it necessarily mean that dopamine is the cause of bipolar, or let me say depression rather? Is that the case? No. We're not saying exactly that dopamine is the cause. All right. And dopamine has a lot of other function, you see. All right. So which means that there is just a correlation being identified that, okay, low level of dopamine can lead to diminished pleasure, which is a symptom of um, depression. Okay, what about serotonin? Yeah. Serotonin, on the other hand, is a hormone that is responsible for mood regulation. Okay? It helps us to balance between our high and then our low. Okay, it's actually very, very important. You need adequate level of serotonin to be able to balance your mood. You know, it's actually a function of human to be able to balance between um, the moment we feel sad and then the moment we feel happy. So we try to balance it so we don't get into the extreme, right? So serotonin helps in mood regulation. Okay, sleep, it helps in controlling sleep and appetite. So low level are a core feature in many depressive disorder. So if you have a low level of serotonin, or for example, low levels of serotonin now can affect your ability to regulate, to balance your mood. So which means you'll be forced to a particular end. All right. So sleeplessness can also be a symptom of depression. You're just overthinking yourself. All right. You can't really get to, I mean, to focus and behave like every other person when it comes to, okay, let me have my normal sleep. But then you are so worried about the issues. Oh, I am this, I am not that. The mood sadness. Okay. Is depression and anxiety the same? Actually, no, they are not the same. All right. So depression is rather a mood thing. Okay, it's rather something around the mood. Okay, it's beyond just the thought. It's rather the mood. Okay. Uh, Moving on from there, yeah. So sleeplessness and then appetite, which are symptoms of mood disorder. Okay. Yeah. Yeah. Brain chemistry, role of dopamine. The evidence now. Dopamine is involved in motivation and pleasure, right? So low level can lead to reduced motivation and hedonia. All right. So you can check this out. All right. So reduced motivation is just low level of motivation, not interested in things. Evidence, antidepressants. Please keep this in mind. It's very, very important. If you're describing explanation of depression, And then you have to talk about the brain chemistry, the neurotransmitters. So if you're discussing dopamine, explaining how dopamine can be a possible cause, all right. So ensure you add the evidence that antidepressants that increase dopamine level can reduce depressive symptom, all right. So there are antidepressants. Don't forget, who can remember the drugs we mentioned for schizophrenia? We spoke about antipsychotics, right? So we have antipsychotic medication. So when it comes to depression now, we have antidepressant, okay, um, which represent, sorry, excuse me. Okay, so sorry about that. Antidepressants increase dopamine level. So, and when they increase dopamine level, they tend to reduce depressive symptoms. Okay, so what about that of serotonin? It regulates mood, sleep, and appetite, right? So, SSRI, this means selective serotonin reuptake inhibitor. All right, so they improved mood by increasing serotonin level. All right, so this is an evidence, and this actually also treats depression. So if they increase serotonin level from low to balanced level now, and that way they are able to treat depression, then it means that serotonin is a possible cause, right? Yeah. Okay, so issues and debate as regards the measurement and explanation of depression. The BDI and similar to may not capture depressive symptom accurately in non-Western culture, right? Due to different symptom expression and language. So the language and then the different ways we express things, all right? You might think that we are universal. Yeah, we are actually universal in our nature. There are also universal culture that we can identify in all cultures, okay? However, there are still some significant relevant behavior that are particular to certain cultures, right? So the way people express depression in some cultures, might be different from the way others express it. So the question targets certain behavior. The behavior might not be general, so that is the thing. Okay, what about nature versus nurture? All right, when it comes to clinical psychology, we have to talk about nature versus nurture debate a lot. Okay, so biological explanations, talking about genes, neurotransmitters, imbalances. Okay, they emphasize inherited predispositions, and all those things are what? Nature. Biology is nature. All right. So biology talks about nature, and biology also can be reductionist. Okay. All right. So the psychological aspect on the other hand, which is the environment, explanations such as trauma, learned helplessness, which is we are still going to talk about, highlights the role of life experience. Okay, things that you learn over time and then can affect you. We're going to talk about learned helplessness soon. Okay, yeah, genetic contribution to mood disorder. Looking at the study of Orukatal. So, family twins and adoption studies support genetic link for mood disorder. Now, investigated association between polymorphism in serotonin receptor and transporter genes and bipolar disorder with implication for depressive symptoms. Now, what this basically means is that Orukatal tried to look at gene polymorphism. When we talk about gene polymorphism, we are talking about the flexibility and the dynamism. All right, it's just like, okay, let me paint it this way. um, Imagine something that changes every 10 minutes. Okay, so now if you study the thing that, okay, this thing changes every 10 minutes, now you want to see the changes. Is the changes in this person every time that you have identified that, okay, in the normal people it changes every 10 minutes, is it going to be changing the same way in the depressive patient? All right, so that is an idea around the polymorphism. All right, the changes, the flexibility, the dynamism of the gene. All right, so they try to focus in particular on the serotonin receptor and transporter. So serotonin receptor, there is a particular gene which is referred to as the serotonin receptor. All right. There's another gene which is referred to as the serotonin transporter. Okay. So they want to look at the polymorphism in those genes by comparing normal people, bipolar people, and depressive people. Right. Okay. So findings, there was no significant difference overall. When they looked at the polymorphism, they discovered it's actually the same in normal people, in depressive people, and the bipolar people. However, very important now, the only thing they found positive there is that polymorphism were more common in women with bipolar disorder. All right. So when they look at women with bipolar disorder, they discovered that okay, polymorphism were more present. That is, the change there, the dynamism there was different compared to normal people. Okay, so this can only help us to predict that there is a small genetic susceptibility that might interact with other factor, for example, the environmental trigger. Okay, also the conclusion from this is that this can help us to predict for women alone. If we notice, okay, a particular polymorphism pattern in women, it might enhance the predictability that such woman or such women, okay, can develop mood disorder when it comes to focusing on the serotonin receptor and serotonin transporter. So that is the conclusion from the finding. So it only affects women according to this genetic discovery. All right. So basically, this study shows that there is more to depression than gene overall, because we did not find significant difference in the entire population used. The only difference we can have is around women. Okay, so keep that in mind. Yeah, so polymorphism, a genetic variation that may affect individual susceptibility to mood disorder. All right, so sexually dysmorphic difference in trait between male and female that might influence disorder risk. All right, so I mentioned that earlier. Now, still on the explanation, we have the Beck cognitive theory of depression. Okay, so don't forget the BDI, Beck's depression inventory. All right, so it's the same person that came up with the explanation. All right, talking about the thought process. How do people develop depression? Okay, now he said there are 3 stages. Number 1, negative view about oneself. You start from here. Okay, you feel worthless, inadequacy. All right, you feel you have a negative view about yourself, and then the negative view about yourself moves to negative view about the world, processing or perceiving the environment as filled with insurmountable obstacle. So there are things in the environment, yeah. For example, I am very poor, or I am bad at, or I can't do anything, or I'm not good at doing things. Okay, I'm not good at doing things. All right, so everything in the environment or in the world is too difficult for me. Okay, now negative view about the future, expecting failure and hopelessness for upcoming events. So I will never be able to do anything successfully because everything around me is too difficult, right? So this is about yourself, and this is about things around the world becoming too hard for you. All right, and this is about future expectation that is going to last like that for the entire time the person is spending on earth. Okay, so this thought which revolves, okay, 3 2 1 3 2 1 3 2 1, like that. All right, according to Beck, is the theory of depression. Okay, yeah, moving on. Beck's cognitive distortion and schema in depression. So what is schema? Organized unit of knowledge that shape how individual interpret experience. So I like to put this as a label. Schema is a form of label. All right, so as you're growing, you're forming certain beliefs that helps you to label certain things, right? You can have a particular perception about something. All right, just you're forming a set of knowledge, okay, such that when you see other things, you use those knowledge to interpret what you're seeing. Okay, now what is the impact of this on depression? Negative schema often formed in early life, all right? Biased interpretation of events and contribute to depressive symptom. Okay, you're actually trying to do something, something bad happened, so you form a particular knowledge about that. Negative schema, negative belief, negative perception. So you begin to think that, okay, when next I want to do something, or maybe I'm a bad planner, I can't do things at the right time. Okay, and you begin to feel bad that, okay, due to experience things around that, you won't be able to do anything positive anymore. Okay, so that's the Beck's explanation. Now, moving to another explanation for depression, we have the learned helplessness and attributional style, right? What is learned helplessness? You know, helplessness is a state, is a feeling, right? That, oh, I'm helpless. You can actually learn it. All right, there's this study that was done with a dog. Yes. So I don't really want to explain that. That's going to take a long time. Okay, but actually, the dog found itself in a difficult situation where every part of the cage if he was in was can be electrocuted. All right, so which means that whatever situation, he couldn't help the situation. He tried all the possible means. Imagine, okay, being drowned in the sea. You try to survive. You try to go up, and then you can't just do anything. Okay, you know, before you actually give up, before someone gives up and gets drowned. Okay, so you've actually learned that I think there is nothing, there is no way out, and then you give up. The person then drowns. Okay, you know, because everybody possesses the ability to actually be able to survive in water without breathing to some extent. You can hold your breath. Okay, the moment you release it, that means you give up and then you release it, right? Because you can still hold it more, but you give up and you release your breath, then the person begins to drown, right? So that is an idea around learned helplessness. Now, it is developed from enduring uncontrollable, okay, adverse situation. You're trying to endure some situation, but at some point you give up, leading to a belief that outcomes are uncontrollable. All right. So if you get to a point that, oh, I can't control the situation is just overpowering, it's too much for me, then you learn that, okay, yeah, I am helpless in this situation. All right. So how does that lead to depression? There's a concept of attributional style or explanatory style. Depressed individuals tend to make internal, okay, it is my fault, all right, stable, all right, it will be this way for a long period of time, all right, and global, it will affect everything. So they have this three things when they find themselves in a situation where they feel that, okay, I can control the environment, I can control the situation, the circumstance, it's overpowering, it's too much for me. All right. So there is an internal element there. It is my fault. They blame themselves, just like the Beck's cognitive triad, right? Internalize, okay? You feel negative about oneself, it is my fault. All right. The second level of Beck's triad is now the global, okay, like the world rather. Okay, the second level is the world, that okay, everything in the world is affecting or is too difficult. However, for this situation under learned helplessness, the second level is stable. This thing is going to last for a long period of time. Okay, which kind of looks like the future. All right, and then the last one now here is the global, and the last one for Beck is the future. All right, so every other thing the person does in the future is not going to be good. However, for this one, it affects everything. Attribution to or for negative event. Okay, so like negative things are going to happen. So I can't control the situation. Yeah, it's my fault. If they just feel that okay, the thing is about the event alone, but not about them, then they are not going to feel bad, right? But depression, they must feel something internal. There is something about them. They blame themselves for something. All right. Then the stable, it's something that will last for a long period of time. Okay, because if they feel that it won't last, then they will be encouraged to overcome it, right? and then global, it affects everything. So moving on, I think I dwell a lot on that. Now, key study by Seligman et al. 1988. He compared depressive patient with non-clinical control, that is normal people, right, using the attributional style, questionnaire, and BDI. What was the findings? Depressive participants showed a more pessimistic attributional style. Okay, pessimistic, that is not having hope, not having zeal, not having passion for the future. All right, so they showed more pessimism under the attributional style. Okay, improvement in attributional style were correlated with reduced depressive symptoms after therapy. Now, so when they gave them a therapy, there was a reduction in their depressive symptom, and that increased their score under the attributional style. So which means that attributional style, all right, and depressive and the BDI, okay, which kind of correlation is that? We can guess. Can you think around that a little? That is actually negative correlation. So if your score under the attributional style is increasing, okay, so your score under the BDI should reduce. Reduce BDI score means that, okay, you're performing well, right? Okay, so something like that. And then if your score under the attributional style is becoming very negative, okay, then your score under the BDI means your depression is level. So you should have a high level of depression. Okay, so moving forward, integration of biological and psychological factor. Okay, how can we combine these two factors under the explanation? Genetic predisposition. It increases vulnerability to depressive disorder. All right, so gene can increase vulnerability. However, it is not the major or the only cause, right? Now, environmental trigger, life event and stressors can actually trigger depression. What about cognitive? So basically, for example, like trauma or previous experience, things that happen to someone can actually trigger them. Okay, what about cognitive process? Determine onset and severity of depression. So the way you process the thing, your schema now, the belief system that you form can determine how severe, can determine when the depression will start. Okay, now determinism versus free will in depression. Genetic, I said, are often deterministic. Okay, genetic and biochemical are deterministic because you can't really control them. They are more of natural. So they predict the behavior. They help us determine. They help us predict. Suggest that certain aspects of depression are predetermined, not by your choice, but they are predetermined. They are determined by genes. Okay, so genes determine how tall you grow, for example. So they are determined, they are predetermined. Okay, what about free will? Free will, on the other hand, is about your choice of life. Okay, so psychological intervention, cognitive therapy demonstrate that altering thought pattern can improve symptoms, right? Okay, also talking about the kind of way you process the trauma. Everybody can have trauma, okay, but how an individual processes it, okay, the schemas he formed from it, okay, can be the cause of depression. So you can use these two elements to explain. Okay, the genetic part and biochemical part are deterministic because they suggest this kind of behavior will be formed. They contradict the free will. Okay, failure to look at possible thought processes and the likes. Okay, the psychological intervention or the psychological pattern, the way someone processes his mind, his thought, okay, how he learned helplessness. Okay, some people have this ability to fight for a very long time, whereas some others, they just give up easily, right? So that can be a free will thing, a choice. Okay, moving on, measurement and research in depressive, that's the research method in depressive disorder. Now, the BDI provides quantitative assessment, but comes with limitation. We said that already, particularly across cultures, right? Okay, now, research studies such as Oruketa and Seligman illustrate both biological and psychological contribution, reinforcing the need for integrated approach in understanding and treating depressive disorder. Okay, so this is actually producing how we can now combine both elements to be able to understand depression. Now, an accurate understanding of depression can help us to um, provide, or let me say, profile effective solution. Okay. Now, application to everyday life, tailored treatment. Understanding this different explanation can help clinicians tailor treatment, right? Holistic approach raises awareness that both inherited factors and life experience, okay, inherited factors talking about genes, the nature, right, and experience now, traumas and issues of life, emphasize the importance of a holistic treatment, okay. What about treatment and management of depression now? We have numerous biochemical treatments, okay, collectively known as antidepressant drugs. We mentioned that earlier. They work by altering levels of key neurotransmitters. What are the key neurotransmitters? We spoke about dopamine, we spoke about serotonin, okay. Now, we have tricyclic antidepressant, which is the TCAs. What do they do? Now, they were introduced in the 1950s, okay, and still used today. Typically, when other treatments are failed, then they use tricyclics, right? Now, what their function is to increase the level of serotonin and norepinephrine. Okay, take note of that. Their work is to increase serotonin and what? Norepinephrine by preventing their reabsorption. Now, let me explain this. You're still going to need it to understand the SSRI, okay? Because the SSRI works similarly. However, they target different things though. Okay, so this we said target two things now: serotonin and norepinephrine. So these are neurotransmitters, right? Now, okay, let me explain this way. Let's assume that this part now is the presynaptic neuron, okay? This part is the presynaptic neuron. This part, the middle part now, is the synapse, okay? And then this other part is the postsynaptic neuron. Now, the thing is, when we have neurotransmitters, they move from the presynaptic, they move to the synapse, and then they move to the postsynaptic neuron. Now, what we're trying to say here is that when they are moving from this part, they are moving to the synapse, which is like a space, all right? Now, they get into the postsynaptic. Now, what happens when you're having low level of a particular neurotransmitter could be that when you release a neurotransmitter from the presynaptic neuron and it gets to the synapse, it can go back. Instead of going to the post now, it's going back to the presynaptic neuron. So which means that less amount of those neurotransmitters are getting to the postsynaptic neuron, which can lead to the low level of such neurotransmitter. So what happens is that the TCA now, when the neurotransmitters are released from the presynaptic, okay, it allows them to be released. Now, it blocks the space, or let me say that particular entrance, okay? It's an entrance and it's an exit at the same time. So when they are released, it blocks the space such that the neurotransmitters in the synapse does not go back to the presynaptic neuron. I hope you understand that, right? Yeah, it's a little biological in this aspect, but please just take note. All right, so it doesn't go back to the presynaptic, it rather allow it to stay in the synapse. So it leads to increased level of neurotransmitter around the synapse now, okay, which when they move around, eventually they will begin to move gradually into the postsynaptic. So that is the way it actually increases the neurotransmitter, all right, by blocking the presynaptic neuron, okay? In other words, they are blocking the reabsorption. They are blocking them from going back, okay? Now, what about the monoamine oxidase inhibitor, which are known as the MAOI? All right, so the way this work is that when I talk about monoamine too, they are referring to neurotransmitters as well. All right, there are about three neurotransmitters that form this monoamine. We have the dopamine, we have the norepinephrine, and then we have the serotonin. Okay, so this actually targets the three. You can see these three. And how does it do that? It does that by blocking, or let me say, it kills the enzyme that breaks them down. Okay, so let me put it this way: there are enzymes that actually kill these neurotransmitters. Okay, now what this monoamine does is that it kills that enzyme that kill the uh, neurotransmitters. I hope that makes sense. Okay, so it breaks down the neurotransmitter. Uh, it inhibits, like stops the work of the enzyme monoamine oxidase, which breaks down this neurotransmitter. All right, so I hope that makes sense. Okay, so that way, by breaking them down, you are actually, no, by killing, or let me say, stopping the enzyme that kill them now, you are actually making availability for all these neurotransmitters to be available, all right, for some of them, or let me say, for them to be increased around the brain. Okay, now what about SSRI, which is the third one? Okay, SSRI are the selective serotonin reuptake inhibitor. So reuptake, reabsorption, they are similar here. All right. So this basically stop the serotonin alone. Don't forget, we said the TCA, which is the tricyclic, the focus on two neurotransmitters, serotonin and what? Norepinephrine. What about monoamine oxidase? They focus on three, right? Norepinephrine, serotonin, and dopamine. So the selective serotonin reuptake inhibitor stops only the serotonin from being reabsorbed into the presynaptic neuron, just like the TCA, right? Okay. So which actually increase serotonin level, reducing, which will help you to reduce the depression. Now, advantage: fewer and less side effects. Why? Because it is only the serotonin, unlike the TCA and the MAOI that targets more than one. So this one just targets one, so which leads to reduced side effect. Their improved tolerability often lead to better patient adherence. Now, clinical evidence. Numerous large clinical studies show that TCA, MAOI, and SSRI are more effective than placebo. Placebo is just an element that has no effect, okay? It can be water, salt and water, depending on the situation. Right, so according to Funia et al. Study, now suggests that impact of this drug is more pronounced in patients with moderate to severe. So you can see the impact more on the patient with moderate to severe depression. Okay, moving forward, we have the psychological treatment. Now we are done with the biological treatment, talking about using drugs. Okay, we have the Beck's cognitive restructuring. So you can see that Beck did a very good job under depression. He came up with the BDI, which is the Beck Depression Inventory. He came up with the Beck Cognitive Triad, all right, which is a negative view about oneself, about the world, about the future. Now there's Beck's Cognitive Restructuring, a way of restructuring, all right? It's a CBT anyway, all right? A form of talking therapy aimed at gaining entry into the patient's cognitive organization, all right? How the person thought, don't forget the triad, very important. So you are trying to gain access into the person's thinking pattern or thought processes. Now, it focuses on identifying and challenging illogical and irrational thought. It tries to identify those thoughts and challenge it. Now, process: begin with explaining the cognitive theory of depression. All right, that's the triad. You start with that, particularly the cognitive triad, okay? Negative view, this. Now, patients are trained to observe and record automatic dysfunctional thought. They are trained to be able to observe those thoughts, all right? The thoughts that they have, okay, about certain things, they are trained to observe them and to be able to record them. Okay, now what is the process? When they are able to identify all those thoughts, all those behavior that seems like an automatic thought in them, okay? All right, yeah, once you see this thing, it's a bad sign, okay? Now, all those thoughts, all those way of interpreting things that they had, They try to record them, identify them, and record them. Now, the goal, enable patient to independently now use cognitive restructuring to reduce depressive symptom. All right. So they are now able to use cognitive restructuring. That is, they try to move away from those automatic thoughts and they try to experiment those thoughts. Okay, you see this thing and you believe, oh, this is a sign that nothing will go bad. Now you try to experiment. Are you actually sure this thing will go bad? Okay, how about you go and give it a try? Is it actually going bad? Can you see that? All right, so a way of challenging, trying to restructure it, the thought processes. Okay, so that is the Beck's cognitive restructuring. Now, what about the Ellis rational emotive behavior therapy? This actually tries to target the emotion. Okay, so Beck's try to target the cognition. This tries to target the emotion, and then the behavior. So this is the REBT. Now, philosophical basis grounded in principle of stoicism. Now, what is stoicism? Okay, which assert that individuals are affected not directly by external events but by their perception of those events, right? So you know that there are certain things that happen that are beyond our control, right? Yes. Let's say, for example, you plan your wedding and it's rained that day. Okay, so you might not plan for it to rain, right? And then it actually rained and a lot of things did not go as planned. The decoration got damaged. Okay, you couldn't dance. Okay, a lot of things like that. Maybe you're an event planner and then everything went the way it happened. Okay, now is it your fault? No. Okay, yeah, you might want to investigate for that to think that, okay, the person could have checked the weather forecast. All right, but let's move away from that. All right, even the weather forecast might not be 100% accurate at some situation. Maybe you even checked and then no sign that it will rain, and eventually it did, and everything got damaged. Now, is it your fault? Well, if it's a normal person, the person will understand that, okay, well, I think I tried my best, but however, there are just things beyond my control that happens. I just have to accept it and move on with life. Maybe the next time I will be more careful, or maybe the next time I will still continue to do what I'm doing. Hopefully, it won't be like this, right? Okay. And someone with depression, on the other hand, will rather believe that, okay, everything has to do with him. It's his fault. Okay, he blames himself. Now, Stoicism believes that individuals are not directly affected by external events. Now, external events are not really affecting us. It is our belief about those external events that is affecting us. Now, if you find yourself to be faulty, that you are the cause of the rain, can you see? You're the one that failed to plan the event accurately. So you have a perception about the event that is leading you to this depression. Okay, so now, to what extent do you think events are the ones affecting us? All right, are we really affected by the event or the way we think about it? Do you get a point? How we see things, okay, how we see ourselves as a failure. All right, those are the things that are affecting us. Event actually will come and go. Yeah, it is the way it is. Just accept it and move on, right? Okay, there are certain things, we have ups and downs that will happen in life. Okay, when you're going through your downs, okay, it doesn't necessarily mean that you are a bad person. Down moment actually happens to everyone, right? But it is our perception about those things that actually matters. Okay, so that is the rule of stoicism. Now, still moving back to the RABT core principle, depression is seen as stemming from internal construction, namely irrational beliefs and attitudes about event. Okay, now the ABC model, he came up with ABC model. A is activating event. There's an event activating it. However, take note, the event is not really the cause. The major fact here is the B, which is the belief. What is your belief around it? What is your perception about it? And then C now will be the behavior, which is the consequence. Okay, C, which is the consequence, now will lead to the depressive symptoms. Can you see that? Now, there are events that are activating it, really, yes. But our belief now, our cognitive process should help us identify that, okay, yeah, this thing happens to everyone. Maybe you failed an interview. Yeah, at some point in time, everyone can fail, all right? So, but rather a depressive symptom, we have a negative belief around that. And then the consequence is going to be depression. Okay, the therapist help patients to identify and dispute irrational beliefs, a process called disputing, okay, like fighting it, especially focusing on the belief. All right, first and foremost, they will try to identify the activating event, the belief that was formed out of it, and then the consequence. Now, how do they treat that? They dispute the belief, because the activating event will actually happen to everyone, right? But it's the belief that they need to restructure, they need to work on that. They try to fight it, just like the way Beck's cognitive restructuring also try to challenge the cognitive process. So here too, they try to dispute the beliefs. Okay, so effectiveness of REBT techniques like reattributing assist patients in okay, sorry, when they dispute the belief, so yeah, you believe that you're a failure because you fail an interview. Yeah, is that true? What about other people that actually fail interview and then yet they are still successful nowadays? All right. So you try to dispute that. So in other words, you're trying to reattribute, because by trying to challenge also the belief system, you are reforming the idea. Oh yeah, I think that is true. It's possible to fail, but that doesn't mean that you're a failure. You get a point. All right. So it's techniques like reattributing assist patients in evaluating whether negative outcome are due to internal factor or external circumstance. We mentioned something around that earlier. Now, patients learn to reframe their thoughts, you see, reducing negative emotion and improving behavioral response. Okay, meta-analysis. Lyon and Woods in 1991 show significant improvement with REBT. Okay, so REBT actually showed improvement when the did the study according to Lyon and Woods. Recent studies, okay, if 10 et al. 2015 indicate that REBT can be as effective as antidepressant in relieving depressive symptoms. Okay, so that is good, right? Now, issues and debate and treatment, individual versus situational explanation. Most treatment focus on individual factors. For example, neurotransmitters, okay, level, which can be personal, range from one person to another. So the level of neurotransmitter in one person compared to another is individual, right? Cognitive distortion, all right, the thought process is still individual. Whether given less consideration, sorry, while giving less consideration to situational influence. So that is for majority of the treatment. So, however, we can say that the REBT tries to focus on activating events, right? So, but then it only mentions it. It doesn't focus. Yeah, that's the word. It mentions that, okay, there can be an activating event, and there is always activating event. There are events that will activate it. All right. It doesn't really focus on how the event can be so influential to forming that belief. So it focuses rather on the belief system, which is a personal thing, that okay, it's the belief out of the activating event. However, it is true that there can actually be an interview, for example, where you did not just fail, but the interviewer tried to ridicule you. You get a point. So that is a special situation. That is a situational factor that is forming that belief. So it doesn't want it feel that treatment failed to identify such situation, right? Okay, what about biological versus psychological treatment? Biological treatment, they are generally cheaper. When you talk about drugs, they are cheaper, they are faster acting, they act faster, and then easy to administer, but often associated with side effects, right? The antidepressant. Now, psychological treatment, on the other hand, it aims to address the underlying causes. Okay, targets the cause. Benefits are often long-lasting and come without medication side effects, but they are time-consuming. That is the issue, and they can be very expensive. All right. Yeah. So, additional consideration and overall effectiveness. Patient adherence. Would they be able to adhere to drugs? Okay. Fewer side effects in treatment for the SSRI, improve quality of life, and ensure that patients are more likely to continue the treatment. Okay, so this is good. Overall effectiveness, both biological and psychological treatment have been shown to be effective, although the degree of improvement may vary based on the severity of the depressive disorder. All right, so it depends on the severity, so we can't really tell how or let me say which is more effective, but both are actually effective, right? Okay, so that is it. I hope you've learned one or two things from the study. Okay, the next slide we'll be moving to that is impulse control disorder, right? So thank you very much. I hope the video is not too long. Please, if you've learned one or two things, try to subscribe to my channel, and then you can stay tuned for more videos. All right, thank you very much. I wish you all the best.